It's my pleasure to introduce our next speaker, Dr. Madeline Pahl. Dr. Pahl is a nephrology specialist at the University of California, Irvine in Orange, California. She's the principal investigator at UC Irvine in the national study, The Family Investigation of Nephropathy and Diabetes, a multi-center study designed to identify genetic determinants of diabetic nephropathy in different ethnic groups, using a variety of strategies to localize susceptibility genes. So please join me in welcoming Dr. Pahl. Thank you, Dr. Pahl.
Thank you for that kind introduction, and it's a pleasure to be here.
Is that mic okay for you?
I think so. What do you think?
Good.
Can you hear me?
Oh, yeah.
That's never been a problem for me. I'm always told I'm too loud, but never that no one could not hear me. Well, I'm so happy to be at this fun encounter of all of you, and Lori asked me to prepare a little informational talk on the relationship between heart and kidneys and now the metabolic syndrome, and it's entitled Heart to Kidney, Keeping It All in Check. Let's see if I can provide what you were interested in, Lori, and what everyone else here might be thinking about. So go ahead and the next slide. For us nephrologists, for decades, even when I was young, we used to talk about cardiorenal syndrome. And we would talk about the effects that heart failure had on kidney disease. And that kind of makes sense. If your heart is not pumping, my word, it's not going to get blood to all sorts of organs, including the kidney. Thus, there would be kidney disease or abnormal kidney function related to the heart abnormality. But there was also clear evidence over the years that kidney disease could result in worsening of the heart function and heart diseases, which I think everyone's very familiar with. And this cardiorenal syndrome came to be. There are stages of the cardiorenal syndrome people discuss about, etc. But I'm pretty sure what Lori wanted me to address is this new kind of idea, next slide, of what's now everyone's talking about, this cardiovascular kidney metabolic syndrome. And it's the idea that you have some kind of metabolic abnormality, we'll define it and talk about it a little bit later, that it can affect your heart, your cardiovascular health, not just your heart, but strokes and other issues, artery disease in the legs, and that it can also affect your kidneys. And now there's articles, this one just published this year in the kidney journals that describe these syndromes. And in fact, we were getting lectures from the cardiologists about this in the last year or two, and we're thinking, what in heaven's name are they talking about? So it's this new CKM syndrome. And you see in this little diagram, what do we mean? Well, let's say you have metabolic syndrome. Most people are aware, talking about obesity and fat stores, etc. So you'll see in this little picture someone made that if you have abnormal adipose tissue or you're overweight, that it can cause inflammation and this oxidative stress everyone talks about. It can be associated, or people think even possibly lead to high blood pressure. Then it can, everyone's aware of the abnormalities in cholesterol and lipid diseases. You can get heart disease, atherosclerosis, and it can affect the kidneys. And the other way around, your kidney diseases can have impact on these situations through hormones and this plasma renin. We'll talk something about these things that then result in heart and lipid disorders, can aggravate the kidney, etc. So you get the picture. Some smart guys make these diagrams that have 8 million arrows going all around, but you get the idea. One points to one, the other one points back, and there you have it. So the idea is you need to address these things together in parallel in order to alter the processes, okay? So the next slide is, let's define what people think are these syndromes, because you're going to see that if you start looking now for the CKM, that people talk about the effects of these processes on each other. So what is the, say, medical definition of metabolic syndrome when it's applied to this CKM disorder, okay? These are interconnected metabolic disorders. They're joined, right? Number one is obesity. The other is high blood pressure. Some people have obesity and high blood pressure and abnormal lipids. Sometimes just the triglycerides, sometimes parts of the cholesterol. We know that there is strong association with these processes with cardiovascular disease. And we'll talk a little bit more about the frank diabetes, but you could add in here pre-diabetes or early glucose intolerance, where somebody says, no, you don't have diabetes, we'll talk about it more, but you're at risk for getting diabetes. Now everybody talks about that they're pre-diabetic when they have some of these processes, and we'll address that a little bit later. And in addition to these metabolic syndrome being associated with cardiovascular disease, which many people knew about and discussed for years, we also now know, and there's increasing evidence, that it's associated with kidney disease, okay? And further definition in more detail of this metabolic syndrome is highlighted here, okay? Like, what is obesity? That I don't fit into my pants anymore? Well, that's happening, but there are actual definitions. We used to talk about BMI, and we talked about that in the transplant, potential transplant donors. And people would say, okay, you know that BMI is weight by height and some fancy equation. They give you a number in kilograms per meter squared. We used to say if your BMI is more than 25, you're overweight, and then after 30 or so, they're obese, etc., okay? For the metabolic syndrome, a little more strict definitions than when you're going to take a donor for a transplant, but you'll see the numbers there. It's considered obesity if your BMI is above 25, and if you're Asian, because they tend to put more of the lipid or fatty tissues in the organs, mid-belly, they use a lower BMI. But now people are saying, no, that's not enough. Maybe we should be looking at waist to hip ratio. And if there's numbers, as noted there on that slide, that exceed certain amount, those should be considered metabolic syndrome. And somebody said, we can't be measuring hip and waist. We're only doing the waist. So if you see a waist circumference that's significantly increased, that would be associated with this definition of obesity for the metabolic syndrome definition. Blood pressure and a lot of arguments going on as to what should be a good normal blood pressure. But for this definition of metabolic syndrome, what's still in the literature is the blood pressure above 130/85. And then abnormal lipids, okay, which would be typically at this stage, people are talking about triglyceride levels. You know how everybody's looking at that LDL cholesterol, the bad cholesterol. But for this syndrome, metabolic syndrome, because the triglycerides go up when people have insulin resistance or this pre-diabetes, that's what people are looking at. And then the pre-diabetes that I alluded to in the last slide, but defined here, fasting blood sugars, not for like they're saying you meet criteria for diabetes, but for metabolic syndrome, probably above 100. So if you're fasting and your blood sugar's above 100, you have one of these things. To get the metabolic syndrome, just like everything in life, you need more than one. So according to these experts that are talking about this process, if you have 3 of those 5 listed there on that little diagram, then you have the criteria to be called metabolic syndrome. So that by itself may have effects on heart and kidney, etc. All right? But to look for this cardio-kidney metabolic syndrome, people are looking at seriously. There are more processes you can look at. So in the next slide, I put the heart. Remember, we're talking heart, kidney, and metabolic syndrome. So what about the definition of cardiovascular disease? When you start looking at what are the risk factors or things we should be doing to treat people with these problems, they define cardiovascular disease in these terms. And you'll see sometimes people talk about subclinical cardiovascular disease. That's just a fancy word for saying maybe you have the findings if somebody were to be able to take your heart out and examine it carefully histologically, but you don't have any findings or symptoms. You haven't had a heart attack, nobody says you have heart failure, etc. It's subclinical. How do they define that for the purposes of this cardio-kidney metabolic syndrome? If you've had one of these CT scans that looks for calcifications, and many people have these now, if you have calcium buildup in your heart, it counts. Or if someone did an CT angio or angiogram and found disease in your heart, then you would have subclinical if you haven't had any clinical problems. Some centers are actually looking at blood tests that are markers for heart disease. One of them is troponin. The other one is called natriuretic proBNP. And if these are abnormal, or if they do an echocardiogram and your heart function doesn't seem normal, and you didn't have symptoms, then you would be considered subclinical cardiovascular disease. Now for our world, the nephrology world, anyone who has chronic kidney disease, and I'm sure many of you know the stages already, but that are severe, stages 4 through 5. We considered those patients to have subclinical cardiovascular disease because they're at such high risk to have cardiac problems. And there's some fancy numerical score your primary doctor probably has done that looks at the cardiovascular risk. And if you have a very high number for that, you're also, even if you haven't had any heart problems, you're considered subclinical, okay? So now we have metabolic syndrome, subclinical cardiovascular disease, and you're gonna see that in some of the stages of this disorder, there's actual clinical cardiovascular disease, but that one's easy to understand. That means you had a problem. You have known heart disease, blockage of the arteries in the heart called coronary artery disease. You had a stroke, which is typically the same thing happening in the vessels of your brain. You have peripheral artery disease, that arteries down to your legs don't work well. That's the same process. Or kind of a hint that the heart is unhappy, has not been treated properly, and you have atrial fibrillation. That's the abnormal heart rhythm. So if you have these things, you meet either subclinical or clinical cardiovascular disease. So the next slide. What about kidney disease? I know I'm bringing coals to Newcastle here. Everybody is familiar with the kidney disease. And we have typically using serum creatinine, determining the way your kidneys clean your blood, or the glomerular filtration rate, the GFR of the kidney. Many are using that little tiny eGFR, which is the estimated GFR. That means some smart mathematician developed an equation. So I take the creatinine that's in your blood, I plug it into this equation, and that can determine how well your kidneys are cleaning your blood of that compound, of the creatinine. And that's the estimated GFR. When you look at that, depending on how much your GFR drops, you get stages of kidney disease. And a normal GFR is above 90, maybe even above 70 sometimes. We'll take transplant donors, right? So a normal GFR would be that would be, they wrote here stage 1. I got this from a table someone had made. But really, in fact, it isn't. Stage 1 chronic kidney disease is the wrong name. I disagree. It's stage 1, you're cool, you're okay, you're normal. They should make that 0. But then the important part is to look at the different stages. People on dialysis have stage 5. And different levels of GFR listed there are associated with different processes. Okay. For the cardio-kidney metabolic syndrome, if people have severe levels of kidney dysfunction, they're more likely to have the associated problems. And you'll see later on when I tell you about medicines that people are trying to use processes for treatment, that it's important to know what your GFR is. Okay, so that's why you'll look. Stage 4 is 15 to 29. Dialysis people, typically we start not very early, less than 10, but for dialysis, but stage 5 is less than 15. Okay? And typically on dialysis, sometimes if you read things, they don't no longer list the stages, but call end-stage kidney disease, or ESKD. Okay? So, but there you see. And the next slide. Okay, so now we're back to the original topic, this CKM syndrome. No one can say all the long words these guys want us to be. So what are the stages or processes that are associated with the CKM, and what are we going to talk about? What are potential treatments to try to prevent these things from getting worse? Okay. First, if you have no risk factors and you're good, those guys named things better. They called it stage 0. That's what you want to be. You want to be stage 0 so you can prevent these things and maintain stage 0 for your life. What is stage 1? Typically, stage 1 is just excess adiposity or weight increase, or this kind of metabolic syndrome. For stage 2, you have to have this obesity and the metabolic kind of syndrome events, but also you start to have other things, including the lipid abnormalities, and maybe you are at high risk for chronic kidney disease, okay? At stage 3, this is when they start to add these cardiovascular definitions. You'll see you could be subclinical cardiovascular disease, which I already told you how that was defined, or have high-risk equivalents, okay? You're at high risk for having these heart problems. We talked about that equation, et cetera, all right? And stage 4 is you have cardiovascular disease in this syndrome with the other abnormalities. So you see, they're just telling you you're getting worse involvement every time, okay? So in this next slide, I tried to put it in a little more, to give you the idea that things can progress, okay? You can start by just having increased weight, right? Nothing, they can't diagnose you with anything. You just have that. But then maybe you start to get high blood pressure, or you have a little bit of abnormal glucose pre-diabetes, or you eventually get overt type 2 diabetes. You have the high lipids, typically triglycerides, but sometimes also, as you know, the bad cholesterol, and you have low good cholesterol, okay? Then you move on to stage 3, you start to think, ooh, these people have now subclinical heart disease, or they may have even developed overt heart disease. You may start having heart failure, having other problems. Ultimately, everything is involved, and you need to address them all in concert in order to improve outcomes. So how do we do that? They give all these cute pictures, and patients are saying, okay, yeah, like, what are you going to do? What is available for management of this? Okay, so how do we manage the CKM? Oh, well, I hope the nutritionists are here, because nephrologists are useless at doing this. You need to manage your weight and do exercise. Here's what we say: lose weight. Then we just walk out of the room. That's not working, we can tell. And that is very important. In stage 0, it's important because you don't want to become stage 1. And we're all at risk in our society. We all know, oh my word, 30% of people are meeting, depending on the areas, these categories. And we need to get better at having weight loss counseling, lifestyle intervention processes that people can sustain and achieve good outcomes. If you target 5 to 10% weight loss, it's been now shown to be associated with some improvement in blood pressure, improvement in blood sugar, and in lipids, particularly triglycerides, which is, by the way, hard to treat with medications. And so it is the key to understanding how to manage this process. If you get weight loss of more than 10%, these have been shown in studies to be associated with reducing cardiovascular events and mortality. So you lose 10% of your weight, you live long enough to annoy your children. Think about that. That's important. Yes? And now we know there's a slew of medications that are available that can address weight loss. And we'll talk a little bit more about that. But everyone knows that now the semaglutide, I don't know, Wegovy, whoever brand name approved by your insurance to be used, has been associated with significant weight loss. And in fact, above 15% of weight loss can be, of the underlying weight can be achieved with these medications. And these have been shown to have good outcomes, including cardiovascular disease and morbidity, hospital admissions, et cetera. And finally, not the prospect of nephrologists very much, but in people who can't achieve significant weight loss, bariatric surgery in the resultant weight loss has its own complications, but has been associated with significant weight loss and in kidney disease, some improvement in kidney proteinuria and other issues. So those are the things. Now, what can you do for stage 2? It starts getting more involved, right? So we talked about that those patients have typically high blood pressure. So what is everyone here knows that nephrologists and their regular doctors are focused, obsessed with blood pressure control. And we typically would reach targets of less than 130/80. My idea is if we're giving you all these blood pressure medicines with who knows what side effects that we don't want to hear you have, we just want to give the medicine. We want to achieve a target. If you're taking the blood pressure medicine and your blood pressure doesn't drop to the target, more aggressive treatment has to be given so that you can reap the benefit, okay? So the target, typically when you read about CKM, using the target of less than 130/80. I'm sure some of you are familiar with the new idea that maybe we should go even lower. And in individuals who don't have symptoms with these things, sometimes reaching the 120s would be a target for the kidney doctors. And I know cardiologists sometimes are going lower, and it's just to let you know, those numbers have been associated with lower strokes and possibly in the elderly, even less dementia. At least it's not making it worse. Huh? So target the blood pressure. Now, here comes the kidney doctor's input. We don't just want to lower blood pressure. We want to do it with certain medications. And I put the category of the medications up there because I didn't have room to be writing 8 million medicines. But when we say the word ACE inhibitor or ACE letter I or ARB, ARB, we're talking about the medicines like lisinopril, enalapril, losartan, valsartan. We love these medicines because they're not only associated with lower blood pressure, but they have been shown for many years to lower the risk of heart problems, cardiovascular events. They lower how much protein is lost in the urine in people with kidney disease, and they are kidney protective. Now, I know people take them, and sometimes everybody here knows about the creatinine, and the creatinine is a certain number. It goes up a little bit with these medicines. We know that can be a problem. But if you look at how fast the kidney is failing, or the slope of that GFR line, when you add the ACE or ARBs, the slope that was going like this, down, 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 will stabilize. And it will add years to the keeping people off dialysis and protecting the kidney. The next thing in level 2 of this CKM is the abnormal lipids. The typical one is triglyceride. That's when you're obese and you need to lose weight and exercise and talk to that nutritionist. We're just saying, get skinny, right? The classic target is to get the triglycerides less than 135. And those, with medicine, that's hard to treat. And the classic one has been the omega-3 fatty acid that works. Exercise works. The statins, which are the atorvastatin, rosuvastatin, Lipitor, Crestor, simvastatin, these medications, lower bad cholesterol. I'm not saying that's not an important thing to do, but they rarely increase the good cholesterol at all, if not just minimally, and they have little to no effect on the triglycerides. So, and there's other drugs that do that, but ideally, we would work on, if you had that problem, the statins are critically important. I'm not saying they're not, but if you're at stage 2 and you only have triglycerides, you have to do the hard labor of weight loss and exercise, okay? And the metabolic syndrome, we talked about weight loss. If you develop diabetes, of course, then the appropriate treatment for that should be discussed. And you see that on the next line down there. If you have diabetes, you need to take that statin. I know they're going, look, that's for the cholesterol. But we know that 2 of them together get a bad outcome for the heart. And you want to get a lower of that bad cholesterol, LDL cholesterol. And if you use the good powered statins, you can even get 50% reduction. Yes, we know sometimes it hurts your muscles. We don't want to hear it. Half the time the muscles are hurting for who knows what. But everybody read it on the internet and calls us on the phone. And then maybe take the CoQ10. We don't know. But in any case, they're important to use because we know the outcomes are greatly reduced. The next ones is you have to treat diabetes. Then I scribble little things on there because the first line of treatment for diabetes is metformin. Metformin is a medication that works really well to control blood sugar, has excellent outcomes, few side effects. It can't be given if your kidney function is poor. If your eGFR is less than 30, there's been reports of abnormal consequences. The worst one is something called lactic acidosis. And so most of the kidney doctors will recommend that medication be removed. But ideally, you should have been on it for a long time if you develop diabetes and your GFR never drops that low because you're controlling your blood sugar. Okay. Many people tell me the metformin causes kidney disease. It does not. It's just that the metformin can hang on in your system if your kidneys are not working and cause this metabolic acidosis. The new kids on the block are these, you've seen the commercials on the Jardiance lady dancing. They are called SGLT2 inhibitors. Okay, you'll see them. There's dapagliflozin, canagliflozin, EMPA, the whole United States of alphabet soup. These medicines make your kidneys incapable of absorbing the sugar back, the glucose. So you excrete glucose. It is, it's a moderately good diabetic medicine, although it doesn't control hemoglobin A1C that well. But it works, but it has been unearthed that there's a slew of additional beneficial effects of these agents. And this SGLT2s have now been shown to reduce urine protein, to protect kidneys, even in people who do not have diabetes. So they had kidney disease from other causes, and they had protein in the urine. It's now, and I think one of them is FDA approved for that process, although we sometimes use whichever one your insurance will cover, okay? But you can use it for non-diabetic kidney disease. And it's also been associated with improved heart cardiovascular events, particularly heart failure. The other fun thing is that these medicines tend to reduce the blood potassium in patients who have kidney disease. And of course, I didn't say it, but many of you know if you're on these lisinopril or losartan, one of the side effects when you have kidney disease is that those medicines will raise your potassium. And the kidney doctors don't want to stop it. No. They want you to lower your potassium by starving yourself from some potassium food or taking those disgusting powders that make you get rid of potassium. But now it's been interestingly observed that if you have the combination of one of these, let's say lisinopril with canagliflozin, your potassium is better controlled. So that's one of the benefits. In addition, it probably also lowers blood pressure a little bit. Patients can waste some salt in the urine. And so these agents are now finding their role in a variety of these disorders, okay? So typically, you have this stage 2. We would want a patient to be treated with lifestyle modification, diet, exercise, addressing their cholesterol, addressing their triglycerides in the ways we described, and addressing their blood pressure typically or urine protein, with a lisinopril and maybe empagliflozin. So you see these things happening. And if they wanted to add for weight loss, the semaglutide or the other agents that are now available, we would say, sure. They probably also have the same protective effects, but they haven't been tested, but they have similar effects. Now, for the medicines that I told you about, the empagliflozin, canagliflozin, et cetera, those compounds, we can't give them if the kidney function is too poor. So they're listed sort of boldly in this stage 2 of the CKM, because you can't have a GFR below, for the SGLT2s, below 20. And the final agent I'm going to tell you, typically for diabetics, finerenone, you can't have if your GFR is below 25. So that's the last category, which really has only been carefully studied in diabetics. But this finerenone is the cousin of spironolactone, which maybe some people with heart failure have been treated. They block aldosterone and the receptors and all these hormones that come from the adrenal gland that can cause high blood pressure, retaining sodium, etc. In diabetics with kidney disease and protein, the addition of that agent has been shown to improve outcomes. Your cardiologists typically use spironolactone, the cheap first agent that was available, for the treatment of heart failure to also protect the heart. But for those you need to have enough kidney function, a GFR above 25, and that medicine, by the way, will also increase the potassium like crazy. So we'd like you to be on all of them, but they have to be carefully managed. Because what we're trying to avoid is stage 3, where you actually start to get cardiovascular atherosclerotic disease. So what you want to do is, if you have subclinical, and I showed you what they think is subclinical, which is a fancy word to say you have the actual process in your body, it just hasn't been bad enough to cause a heart attack, which is what you want to avoid. If you have those, in addition to being treated with these other processes, most patients, by then the cardiologists are giving aspirin to prevent disease, or like Plavix, some people are on those kind of agents, okay? And typically, we think patients should be on one of these statins, okay? And if you have subclinical heart failure, you haven't had the frank heart failure, but they see findings on echocardiogram, okay? By then, the cardiologists are treating patients with, in addition to those ACE inhibitor I showed you, or the losartan, etc., they typically add the beta blocker, like propranolol, carvedilol, agents that also protect the heart. They lower your pulse a little bit. And in diabetics, or in patients who need those canagliflozin, dapagliflozin to manage their blood sugars, they're preferred if people have the risk of heart failure, because they can treat the heart failure, reduce the amount of fluid that builds up, and reduce hospitalization. So you get the idea of the things are moving on. And then for number 4, which is the last one, stage 4 is if anybody has that's what this acronym is, atherosclerotic cardiovascular disease. What is that? That's just plaque that builds up in your blood vessels. When it's in the heart, we call it heart disease. When it's in your brain, they call it a stroke. But it's the same pathologic process. Now, why someone gets more in the heart or the brain or the feet, I don't know. I don't think anybody really knows, but it's the same disorder, okay? And what do you need to do? You see that. Definitely take that darn aspirin the doctor gave you, even though you think it's nonsense, because it will prevent the bad outcome. And this time, not just the statin, not that baby simvastatin, but the high-intensity rosuvastatin, that'll knock that LDL cholesterol down, okay? And then to use the pillars, the 4 pillars of guideline-directed medical therapy. You'll see that when you read things about this, and the acronym is GDMT. I never can remember it, so I like to write it out. And the 4 pillars, when people have significant heart disease, particularly with some heart failure, is 1, that medication that's the acronym ARNI, but this is the one that combines the neprilysin inhibitor and the losartan, or the ARB, okay? It's a combination pill. They give you the beta blocker, the canagliflozin, one of those, and the mineral corticoid receptor blocker, like the finerenone, okay? Those people that have heart failure need to be taking all of these agents. It seems like a burden of pills, but it can protect the heart, try to prevent further progression, and prevent additional kidney failure associated with that. Remember that first one when we were like in our 1980s, we knew about cardiorenal. Now we have to add fancy things. But your heart fails, your kidneys will get worse. Okay? Obesity management, as we discussed, and it's important. People say, oh, already I'm at this stage. No, because even in severe stages, weight management can demonstrate improved outcomes. It doesn't, ideally, it should have been a lifetime, and even in this setting, it's important to manage the lipids, the triglycerides, in addition to the cholesterol, as we talked about, and blood pressure management. We're pretty sure that blood pressures for kidney disease and preventing progression of kidney disease should be at the levels of 130s over 80s. This, we're sure. 140s over 90, no, even. Is it better to go lower? The lower blood pressures have clearly been associated with reduced strokes. They've not been 100% shown, not been shown to prevent progression of kidney disease, okay? But typically, we want to target in the 120s for patients that have kidney disease and other cardiovascular issues, because no one wants a stroke or progressive heart disease. And what we do know is that 120s over 80s, 120s are not associated with making kidney function worse, which is what people were scared to see. I don't know there's data in the 110s yet, but certainly we want blood pressures 130s over 80s or less, okay? We don't want 140s, even CKD4 and 5. In dialysis, it's a lot harder to address these things because of the changes that happen, particularly with hemodialysis. But if a dialysis patient could maintain blood pressures of 130s over 80s when they were off dialysis or off peritoneal dialysis in the day, that would be good, okay? Diabetes, again, we would like control at least to hemoglobin A1Cs below 7%, right? And the agents, lifestyle modifications we discussed, and you know, I told you for the canagliflozin, how you can't use it if the GFR is less than 20, and for the metformin if it's less than 30, and so people may have to use insulin or other measures to control blood sugar. And finally, for the cardiovascular disease, we recommend treating with the statins, and somebody who's going to be smart enough to have looked at the data that really the cholesterol lowerings didn't seem to have much effect on dialysis patients, that maybe the statins don't have much effect at that level. But still, it's recommended that these agents be continued even in that setting. Perhaps the LDL cholesterol isn't being altered significantly, but these medications have other effects to reduce inflammation, etc. So most people, unless there's a problem with the agent, don't stop it, okay? And we already talked about the SGLT2, the canagliflozins. So in my final slide, I would just remind us that metabolic syndrome can mediate cardiovascular risk and kidney disease. And that a complementary management of these disorders, of the metabolic syndrome, protecting the kidney with the medications and lifestyle things we talked about, and the heart can maximize the therapeutic benefits and improve not just outcomes but also mortality. So, thank you.